I'm Susan Branscombe, the host of this podcast, Food Addiction, the Problem and the Solution. Today on the podcast, we welcome Dr. Tro Kalayjian. Welcome, Dr. Tro.
Thanks for having me. Very important topic. I'm excited. Important to me personally, very important to me professionally, important to our whole society. And thanks for bringing me on. We need to build the awareness, and thank you.
Yeah, this is going to be great. I'm going to introduce you with your bio, and then we're going to dive into some topics and some questions. Dr. Tro Kalayjian is a board-certified physician in internal medicine and obesity medicine and the founder and chief medical officer of Toward Health, a virtual metabolic health clinic helping people reverse chronic metabolic disease and food addiction. He is a founding member of the Society of Metabolic Health Practitioners and an international speaker on metabolic health, obesity, nutrition, science, and metabolic psychiatry. His work focuses on personalized, lifestyle-based care that improves metabolic outcomes while reducing reliance on medication. What makes Dr. Tro's work especially powerful is that it's personal. He grew up in a household affected by obesity and struggled with his own weight into adulthood, reaching over 350 pounds. After years of frustration with conventional medical advice, he immersed himself in the research and ultimately lost more than 150 pounds, maintaining that loss for over a decade. Today, backed by peer-reviewed research and real-world clinical outcomes, Dr. Tro combines science, compassion, and lived experience to help people find sustainable health and true food freedom. So welcome again, Dr. Tro.
Thank you. It's very great. All the kind words, and absolutely correct. I certainly lived it at home.
Yeah, you're one of my favorite guests to host on the podcast, and that is not only do you work in this field and you know the brain science around food addiction, but you've had personal experience, and it's a magical combination in this. You and I met in London at the conference. I was there representing Food Addiction Institute in September of 2025. So I heard you speak a couple of times, once on a panel, and then you had a segment to speak on, and listened to you there. I've done my research on you. You're fairly prolific on X, Twitter. I've listened to several of your podcasts. I reviewed your website, and I'm left with a few impressions. One is that you are bold and you are vocal. Right?
My wife agrees.
Do you agree?
I think, the right word is angry. The right word is angry, and you talked about my mom when you started this in my household, and I watched my mom. She took me to Weight Watchers at 8. I remember her up at nights because she was taking fen, knitting feverishly because she couldn't sleep, and to lose weight. And then ultimately, she went and had bariatric surgery, then Ozempic, and then breast cancer, then a heart attack. And I just think to myself that, all along the way, it was in her mind, it was her fault. Doctors did everything. Did they really do everything? Did they really do everything? Did they really make her aware that this food that you're eating that we think is normal, that is served in cafeterias and school lunches and, sold, just in a way that is egregious, right? Is this all normal?
No.
Is this all, did they really explain to her you're dealing with an addictive substance and you're causing self-harm? I don't think so.
No. No. Yeah. Well, my father was obese and I saw him diet, lose 80 pounds, gain it back many, many ways. And food addiction as a disease was not known. It was just not studied. It was not out there. It was just like, okay, get on a diet, lose weight and keep it off, and I have personal experience in that I used to weigh over 200 pounds, and, I'm recovered from food addiction. So I'm angry too, that I'm angry at the food companies. I'm angry at doctors that there are many, many, many millions of people out there thinking that it is still their fault, right?
Yeah, I think that's the problem with I think food addiction. The entire society, obesity in general, chronic disease in general. If you look at chronic disease in general, it's increased over the last 7 decades, and nobody has really been able to explain it in a coherent way, and nobody is taking ownership of it. No doctor is taking ownership of it. No, medical institution is taking ownership. Nobody said, "Oops, we messed up." It's all like, we know what to do, and you should just do what we say. And I think that part of public health is something that needs to change. And um, there's always this top down. Well, if you're responsible for your population, what does it say about you? Over 5 decades or 6 decades that the entire population got sick on your watch. Every physician right now who's practicing, every trainer, every coach, every nutritionist and dietitian needs to take a cold, hard look in the mirror and say to themselves, did we really do everything we should have? Or did we gaslight people into thinking they needed to willpower their way through unrelenting hunger and appetite? Did we blame them through our methodology of budgeting as an approach to obesity? I think the reality is that, like, I was 350 pounds. Every step I took hurt. I was tired all the time. And I had a near photographic memory of calories. You couldn't make me learn more about calories. I could count. Gosh, I scored a near perfect level on my SAT and math. I needed insight, not numbers. I needed to know why I was eating, why I was pushed to eat, not some rubric to control something I didn't understand.
Mm-hmm.
And if the physicians and the nutritionists and the dietitians were not smart enough to tell that that's what I needed, what does that say about them? If my guidelines did not reach me, right? If it pushed addictive food on me that did not work for me, what does it say about them? And what does it say about the scientists who propagated it? So, it's not I'm bold and I'm angry.
Yeah. Well, let's talk about your practice, because you are doing things differently than many doctors. It sounds like it's virtual. Well, I'd like to know more about that. But what are your beliefs around food, and how you treat patients, how you counsel them, and which might be different than other medical doctors? Let's talk about your business.
Yeah. So let's just give a little background on who I am. I'm a board certified internal medicine doctor. I'm board certified in obesity medicine. I was trained in the Yale system. I was a chief resident at a Yale affiliated internal medicine program. I was trained in what they wanted me to be trained in, and yet I was 350 pounds and miserable, physically miserable. And I had access to the best doctors, and the best doctor's advice was take phentermine, count your calories, maybe get a gastric bypass. Oh, did you consider that you could be depressed? And I wasn't depressed. I'm a happy-go-lucky person. I'm not depressed, but I was void of insight. So when I went to the literature, I did what I would have done in any part of medicine. I said, okay, just give me the head-to-head studies. Just show me directly which antibiotic is better. Right? Is what works for UTIs, what works for pneumonia. Just compare the antibiotics and tell me which one's better, and I'm going to do that one. And I went, and it was like literally the opposite of what our guidelines said. The best diets were the ones that were literally flipped the pyramid upside down for weight loss, for diabetes, for hypertension, for metabolic syndrome. And I'm like, what is going on here? Am I in and every study after study after study after study, when I looked at this through the realm of a doctor, not a public health authoritarian, when I looked at it, like, what is going to help the person in front of me, what is done well head to head. When I looked at it that way, it was so crystal clear. And then I went back and read 3 textbooks on obesity, thousands of papers. And you sort of sit back with this beautiful mind moment and you get the whole picture. You get how values and politics and, religion may be affected our dietary guidelines and finances. Gosh, finances, how they affected our dietary guidelines and how it's so in antithesis to what we need to heal. So that's where it started, where I just said, let me go figure this out. And that changed the way I practice. When I saw, my first day as a practicing doctor, I remember the doctor that was mentoring me said, don't let the patient sit down when they come in, because when they're riled up and you take their blood pressure, it'll be elevated. And then you can legitimize getting an EKG, putting them on a medication, and bringing them back in 3 months. This is what I was told.
Oh.
I didn't get that in my residency. This was private practice. And the first week, I decided I have to get out of here.
Yeah.
I have to get out of here. And then, the other partnering physician would ask me for narcotics a month later, which made it even easier for me to leave that private practice. But you can't, if you ask about my business, you have to understand that our modern occurrence-based, insurance-based way of practicing doesn't work. And when a patient pays me and I am on the hook for their results and their happiness, right? Then the financial incentives are aligned, right? So if I don't get your family member results and they leave my practice, right? This is, or if I don't get you your results, right? And you're going to leave my practice. You're not going to pay for me.
Right. So how do you do it? Somebody comes into you that's 100 pounds overweight, high blood pressure, diabetes. Do you screen them for food addiction? What do you do?
Yeah. Well, first things first, we now in 2026 offer a guarantee. The guarantee is if you keep a stable blood sugar and you maintain ketones, okay, and you step on a scale, that if we don't achieve results within 6 months, that we will give you 6 months more of medical care for free.
Wow.
So that's the first thing. We're putting our money where our mouth is. Okay. The first thing is we're putting our money where our mouth is. And I don't know of any other clinic that does that. We don't guarantee results. We say, if we don't get the results we believe we can, we will care for you for another 6 months. So that's one. And with our employer contracts where we work with employers, we also offer a guarantee, meaning we don't get paid. We give back half of our money if somebody doesn't lose weight, improve their A1C, improve their blood pressure. So the financial incentives in our practice are 100% aligned with somebody succeeding. Okay, that's step one. Step two, yes, every single patient is screened for depression, anxiety, adverse childhood events, food addiction, binge eating, domestic violence, right? Every single person uses biofeedback tools. Every single person will meet with a health coach, will be onboarded within a week of starting. They will have an app with curriculum deployed to them within a week of signing up, right? Because we want to strike with the iron heart. There will be live meetings they can attend within a week of them signing up with us. They will have comprehensive lab work. Their heart will be evaluated. Their genetics may be evaluated. So yes, it is a very comprehensive and in-depth assessment. People with food addiction are educated on food addiction. People with binge eating are educated on binge eating and given strategies specific to them. People without any of those may focus just on nutrition and metabolic health. So we try to
Mm-hmm.
determine the patient, what their needs are, and put them into a track where they're best fit, and we're on the hook.
Mm-hmm. How do you do
Right?
it virtually?
Yeah, we have nationwide contracts with lab companies. We ship out scales, cuffs, continuous glucose monitors. We have nationwide contracts with imaging companies.
Mm.
So we can get imaging labs, send it to medications if needed to any pharmacy nearby. We're a nationwide medical practice, and we have been for last for the last 7 or 8 years.
Mm-hmm. Yeah. Your practice is, people can find you by Toward Health. We'll make sure that's in the notes. And you said that they meet with a health coach. I know how you, from my research, how you feel about low carb or no carb, keto. Can't tell if it's carnivore, but does the health coach prescribe a food plan for the people, how to eat?
The patient described the patient actually first will start with a what has worked for you and historically, right? It'll be a full assessment of their dietary history, weight history. You'll have a full assessment of their cravings, their problem foods, places, people, situations, right? If you've struggled with pizza your entire life, well, we better figure out what to do with pizza. If you've struggled with chocolate your entire life, we better figure out what to do with chocolate. So the assessment is holistic, and I think the diet plan is very rarely relevant. It's really based on the patient. Like most people coming to us have metabolic syndrome diabetes, and in those cases, some version of carb restriction is appropriate and ideal. Now, if somebody says, "I'm vegan and I want carbohydrates," we certainly have to just accommodate that, right? We're not going to be able to, so we have to work with people and be flexible.
Mm-hmm.
There's many ways to achieve metabolic health.
Yeah.
But we are very favorable. The data is very consistent. Metabolic syndrome, binge eating, food addiction symptoms are improved with low carb diets. Several studies with binge eating and food addiction symptoms have been lowered with low carb and ketogenic diets. So I think you just have to follow the evidence. If somebody doesn't want to do that, we have to respect their wishes.
Mm-hmm.
But yes, the coaches help make the prescribed diet something that's realistic.
Mm-hmm.
And they're an integral part of our practice. Coaches meet with patients maybe 20 times in a year.
Mm-hmm. Yeah, the food plans, in my program, we don't judge other people's food programs. Some people have trigger foods that aren't my trigger foods. Nuts are fine for me and cheese. Sounds like you're more focused on, at least from the X post that you have, more like meat, eggs, cheese. I eat 20 ounces of vegetables a day, 15 ounces of fruit, and 3 servings of carbs. That's 1 ounce of bread or 3 ounces of potatoes. And my numbers are good. I'm at a good maintenance weight. That's what worked for me. So,
That's awesome. I'd say
yeah.
if it's working, don't change it.
Yeah, it doesn't look like I need to change. It's worked for 9 years. So
Yeah.
I'm 67 and looks like I'm going to live through this. But
Knock on
you
wood.
don't
Knock
not
on wood.
support. What's that?
Knock on wood.
Knock on wood. Yeah.
Yeah.
Yeah. You don't. It sounds like you eat. Like, let me just ask you about your diet. Like what
Sure.
you eat.
Yeah.
Do you eat any carbs? Do you eat any bread, any pasta, potatoes at
I
all?
haven't had bread in 10 years. I haven't had a
Okay.
potato in 11 years. I haven't had pasta in 10 years.
Okay.
I don't think I've had a banana in 8 years.
Okay.
I haven't had an orange in, my kids eat these things, just mind you.
Yeah.
Not pasta, not really pasta or bread or they do eat plenty of fruit. Interestingly, my kids, I'm homozygous for several genes, so which means technically they would have those genes. And I was 100 pounds heavier than my son at his age.
Mm.
But yeah, very little cereal, for example. I don't remember the last time I had cereal. So my today I had eggs. I had some sugar-free gum, and I'll probably eat steak for dinner, maybe a salad, maybe vegetables.
Okay.
Yesterday I had broccoli and chicken for dinner, and I had bone broth for lunch. So
Hmm.
let's see.
Do you eat any fruit?
Yeah, I'll have berries.
Okay.
Occasionally, like if I'm gonna do like a race, I may if I'm gonna do like a 5K and I want to perform as good as my son, maybe I'll have like an
Better than
orange.
your son?
You know, well, he's so fast. He's so fast. My
Yeah. How old is
13-year-old
he?
he's 13 and he's running 15 miles. At his age, I was running 13-minute miles.
Wow.
Yeah, yeah. So yeah,
Fantastic.
but
Yeah.
that's kind of what I eat. And I think the X doesn't do justice to nuanced discussion. But I eat meat, eggs, fish, chicken, um, tons of green leafy vegetables. I
Okay.
would consider any of those unlimited foods for me.
Mm-hmm.
Um, I get very cautious around nuts. I get very cautious around cheese because for me personally, I tend to overdo those.
Mm-hmm.
Some people do really well with those. Um, I I am cautious around fruit
Mm-hmm.
just because I can eat endless fruit. So
Yeah.
I'm cautious around those. But in terms of our practice, we consider green leafy vegetables and essentially not an unlimited item. We certainly don't want people to eat to the point of ill health, but you can
Mm-hmm.
have it freely. You can have protein rich uh, real foods relatively freely, and most other foods, processed foods or nuts and cheese. Nuts are usually coated with roasted in the seed oil and salted,
Mm-hmm. Yeah.
and cheese has unique characteristics to it that I think could make it slightly more addictive versus other foods. But I think they're both healthy. That's the other part of this
Mm-hmm.
discussion. Both nuts and cheese are very healthy. I do think fruit is certainly in moderation is healthy.
Yeah.
Um,
And we know that fat doesn't make you fat alone. I mean,
yeah, I think
I
fat
eat a
phobia did a lot of harm
yes.
for most. And honestly, I think it hurt women. It
Yeah.
hurt women. A generation of women were
Yeah.
harmed by
Yeah.
fat phobia.
Mm-hmm.
The only fats I would be concerned about are processed oils. I'd be
Yeah.
concerned about those.
Yeah. Um, Talk about the patients that you have come in, what you think about food addiction versus the psychological addiction. And we talked a lot in London about eating disorders versus food addiction, binge eating disorder as a psychological um, diagnosis versus food addiction. We know there is a difference. I know you've worked with Dr. Sotomoda, who's proven that binge eating disorder and food addiction are separate. There is a separateness to them. Talk about those people. Something people don't understand about food addiction.
Yeah. So I think you have to start with what is sort of what does binge eating look like? What does binging look like? And it's a spectrum. How do you go from maybe use to harmful use to occasional binging to regular binging to binging with food addiction to fulminant food addiction. And I think I just described a spectrum really of disease. And the first thing you have to do is, if you're thinking about this thing, is one, is it bringing you physical or psychological distress? I mean, this is the key hallmark, right? I drink alcohol, for example, maybe 2 or 3 times a year, and it brings me no psychological distress. My use, it's something I don't think is quite healthy. I limit it in my life, but I have no problem living it. And when I do imbibe, it is a conscious choice that I'm making and I'm happy with afterwards. So, and there's no sign of ill health because of my use. So
Mhm.
this would be a substance that maybe I would be at risk. It would be at risk behavior, right? It's something that I know is harmful. I work to control and I successfully control, no ill health, right? When you're taking that step further, right, and that could be, you can apply that same principle for food. Somebody who has occasional indiscretion, because it's so occasional, they're perfectly fine the way they do it because they're so controlled. There's no psychological distress. They don't eat to the point of ill health. They're not having consequences from the food. Right? So this may be somebody who's just at risk. Harmful use would be you're eating the Doritos despite gaining weight, despite feeling terrible. Maybe you had a diabetic ulcer and you're still eating the same way. Maybe you get migraines and you're still eating the same way. Now this is harmful. Or maybe you ate so much where it's hurting, like you're refluxing, you're burping up food, it hurts your stomach, or you eat so quickly, there's a shame and guilt associated. Maybe you're often hiding, or you don't want people to see it. So this has now gone to harmful use, and you're towards the sort of disease spectrum. If you like if one time a year, Thanksgiving, everybody eats to the point that it hurts, right? Does that, not saying it's normal behavior, but just eating to the point of feeling really full is not in and of itself a sign of binge eating. But
Mhm.
when you do it so regularly and so frequently that there's psychological distress and ill health and weight gain, then, I would consider binge eating. So if you're out there and you eat a lot on Thanksgiving, well, don't come and see me, right? But if you're eating like that throughout the week, or weekly, this is a concern, right?
Mhm.
Particularly if there's a lot of psychological distress around it or physical distress. And binge eating is screened with a binge eating scale. You can look up BED7 or binge eating scale. Either one of these are good screening tools. Now, the question of food addiction, what makes that different? I think food addiction, the symptoms intensify. The consequences are much greater typically, right? The psychological distress is much greater. And there are questionnaires you can use to differentiate the two. The food addiction scale is one of those. The YFAS 2.0 is a good,
Yale food
yeah,
addiction scale.
yeah. So these are the things I would use. You could just take them online
Mhm.
and sort of assess yourself.
Mhm.
Uncope, I think, is the one that Jen Unwin uses.
Yes.
We use a quick and dirty. It worked for alcohol. It works really well. A cage questionnaire in our clinic, modified for food.
Mhm.
And they are distinct entities, but I think they're on a spectrum. And if you're eating despite consequences, I'll give you my own example, and I'll make this super quick.
Mhm.
I would have incredibly stressful scenarios in the hospital overnight. I would, after a code, oftentimes just be so down or so depressed, or just momentarily not depressed, but like just sad. Somebody passed away, where I
Mm.
might, without even thinking about it, eat my neighbor's chocolate, eat the protein bar that's on the desk, two of them, three of them sometimes, and then it would hurt. I would eat three protein bars, and you're not happy in the
Mhm.
toilet after you do that.
Yeah.
Or sometimes I would hide the wrappers. I'd be so ashamed because I had that chocolate that was sitting on the table that I would hide the bars, the wrappers, or I'd hide the chocolate wrappers, or maybe I would avoid. Like I would eat food in my car on my way home, and then come home to my family and eat. And so my car would have some wrappers, or maybe I would eat ice cream at home, and
Mhm.
I just didn't want to hear it from a family member, so I would hide it. So those if you have any of those things, please call me.
Yeah.
Right? Yeah.
Yeah. Yeah, the hallmarks of food addiction, as we know, are similar to those of alcohol and drugs. We'll talk about food addiction as a substance use disorder, and the characteristics of addiction we know, our craving, our withdrawal. We can't stop from starting. We can't stop once we start. That's what happens to alcoholics and drug addicts, and that's what happens to many of us when we eat our addictive foods. We want more. We need more. We can't stop. And despite negative consequences, as you say, and many of us eat out of not wanting to feel things, or when we feel things, we want to stop feeling them. These can be rooted in, you alluded to childhood trauma, um, but you had listed in one of your recordings the top most addictive foods, which are some of my old favorites. I think every one of these: pizza, chocolate, ice cream, French fries, potato chips, cookies, cakes, and donuts. And we have our little favorites, and there's a lot of shame around this. I've been known to hide wrappers too. I know many people that have done those food behaviors to kind of keep people from knowing. But with obesity, we wear this disease. People can tell, even though they don't see us eating, we are, right?
Yeah. Yeah. Look, it's you don't have to suffer alone. I think that's the other thing. Like, a lot of times this is, I don't know who said this, but I'm going to repeat it. The opposite of addiction is community, right? The opposite of addiction is community. And there's a lot of healing in community, right? Because you need a perspective and identity change, and it's very difficult to do alone. I wish I wasn't alone. I wish I had insight. And that's what our practice is really about. Every single person in our practice, every health coach has been touched by food addiction, lost weight, and maintained it. Every clinician has seen the impact of metabolic health firsthand. We have a full food addiction curriculum on our app. We have live meetings you can go to. One of our coaches, Tia Reed, is a food addiction specialist. So I think part of this, when you're riddled by shame and guilt, it's very difficult to self-assess properly. So get help. Just get help.
Yeah.
They proved this, like, the most effective model for alcohol addiction is not medications, it's community.
Yeah.
Right?
Yeah. It is. I'd like to segue into your personal background with that. I'm curious, when you talk about community. I use a 12-step program in my food recovery. Have you used a 12-step program in food recovery?
No, we don't use a 12-step program. We've probably borrowed some of the elements. I would say, if you had to give the best example of what it is we do, it's probably closest to cognitive behavioral therapy for food, around food. It is a process of learning and feedback, creating open rapport, making sure there's a knowledge base, a communal, knowledge base. It's funny, the word university, right? We were talking about schools, university, universe, one verse, like a common language, understanding something in a very similar way. So we start by educating on food addiction. And then we try to pick apart week by week the cognitive or emotional sort of or psychological barriers to maintaining a dietary program. We don't focus so much on the nutrition. A lot of the nutrition is simple. Honestly, I don't care. As long as your line is flat, you make some ketones. I don't care how you do it. I don't care. You need nourishing food. Here's the alternative. 90% of people coming to me are malnourished.
I bet.
Vitamin deficiencies, right? They're wildly overweight, average 290 pounds, but are malnourished.
Yeah.
Right? So how do you tell somebody to count their food and count their portion and this and that? Just go eat filling food.
Yeah.
Go eat filling.
Not
Your brain is starving for food. Go eat filling food. Go have 2 pounds of fish and then come back and tell me if you're just uncomfortable.
Yeah. But
Right?
you say no sugar, right? No ultra processed foods or
Yeah. Oh, 100%. Yes. Keep the
okay.
line flat.
Yeah.
Keep the CGM line flat. Make ketones.
What CGM? I heard that on your podcast. CGM.
Yeah, that's a continuous glucose monitor.
Okay.
So some people may be able to tolerate a little bit of fruit and they don't get glycemic excursions and hungry afterwards from it.
Mm-hmm.
Do it.
Yeah.
Go ahead. If it works for you. If it
Yeah.
makes you more hungry, don't eat it. Period.
Yeah, that's
if it makes
for
you more,
sure.
if it's not filling you, don't eat it.
Right.
If your problem is you can't restrict food or you can't restrict quantity or you can't restrict quality, then don't eat the food that's making you, don't eat it.
Yeah.
Or figure out a way to eat it that doesn't make you or less harmful.
Yeah.
Right. But the basis is starting with education. We use biofeedback tools. What we do in our visits is most similar to cognitive behavioral therapy. It's just trying to heal that relationship with food.
Mm-hmm.
A lot of community-based courses that people can take and classes people can come into.
The community part is big, and it's big in 12-step. We have fellowship. We are not alone. We have meetings and so forth. And let's kind of dive into your personal recovery a bit more. You had said that in my research, you said when you weighed 350 pounds, you heard your wife confront you, I guess, by asking you, "Are you going to die?" This is maybe before you had kids, or maybe your kids were small, and she was probably like kind of worried about that. And then
real questions,
and then you also said, and this is a quote, "I first realized I had a difficult relationship with food when I was talking to a patient who had a problem with alcohol." So you saw alcohol addiction, you thought, "Oh, that's how I use food," right?
So when I first started dieting, right, to lose weight because I was concerned about my health, it was triggered. My wife knew how to play me. I was an arrogant shithead, and she just knew how to play me, 10 years ago, most of my life, I'd say. So she just played me. She's like, "Look, you're a smart guy. Go figure this out. Like, you're chief resident, this, that. You're going to be alive." Legitimate question. I don't think it was fear that inspired me. I think it was more like, she's right. Let me go do this. It's not about me anymore. There's more people than just me. And so I just did what the literature said to do at the time. This is 2015 or 2014, and the literature said do low carb. That was it. It was simple. Then 2 years into low carb, I'm on my own practice. I'm helping people. I'm doing a cage questionnaire on alcohol, and then it's like a light bulb moment. Like, wait a second, right? It's not, food is a substance, right? And it wasn't that I was addicted at the time. I wasn't. I was in my recovery. I didn't know it, but I was well into my recovery. I had already lost 120 pounds by then. But I understood my behavior, and I understood the implications. Like, why would somebody hide and sneak food? Right? Why does somebody do that?
Yeah.
And it's because the shame and the emotions are so intense. The shame and the guilt are so intense, and you're so captivated by the food. It's easier to hide your use than stop your use.
Mm-hmm.
That's hiding and sneaking. It's a shame management tool. It's a guilt and shame management tool, right? It's an anger and stubbornness, quote unquote. Why do you feel anger and stubborn? Why do you feel that way? Because it's something you cerebrally want to give up, but for some reason you can't.
Mm-hmm.
That's why you feel opposite. It's like if somebody says, hey, don't drive on a flat tire, it's so easy for you. You're like, yeah, of course I wouldn't drive on. I would fix this tire. Somebody says, don't eat the pizza. How many people say, of course I wouldn't eat this pizza. Of course I'm going to have the grilled chicken. Who says that? Nobody says that because we're captivated by the substance.
Mm-hmm. It's got a hold on us. We're not free from it.
Yeah. So when I understood, that light bulb moment was very meaningful for me. And then at the same time, right around that time, Laura Saslow, messaged around saying, hey, anybody noticing food addiction symptoms getting better? And I was like, I have 3 patients. I have 3 patients already. Right? I measured their binge eating. I measured their food addiction scales. Like they went down, resolved. I have it. I failed one of them. I'll be honest with you. I failed one of them early on. She said, should I take sweeteners? And I said, of course you should use sweeteners if that's what gets you off it. I embraced harm reduction for many years without really fully giving credit to the power of abstinence. There is a power of abstinence, and only the person can decide what's right for them. And I can't decide that. So I wrote that paper. On binge. It's been cited 100 times now. Ketogenic diet and improving binge eating and food addiction symptoms. And when we were publishing that paper 10 years ago, we were so worried what everybody was going to think, because it was crazy. 10 years ago, it was crazy.
Yeah.
And now how the world has changed.
Yeah. Let me ask you about that as you go there. We've talked a lot in the Food Addiction Institute, and I know you've talked to Michael Prager, the tenets, and should we be so firm on abstinence versus harm reduction? Do you exclude people who are trying to see if they have food addiction? And in one of the podcasts, you said, I feel strongly, and this is a quote, ultimately to treat any addiction, abstinence is key.
Yeah.
So I can't eat just a little sugar. I can't just eat a little pizza. I want more. So I have to be abstinent, just like alcohol. It's not like I can drink a glass of wine and be okay. So talk about abstinence versus harm reduction. How important is it in treating food addiction?
I think that food addiction is a very unique type of addiction. How can we be addicted to a substance that also gives us energy and nourishes us? Right. So I think you have to talk about it. And we're so clever. We're so clever as a species. Like, gosh, like sugar is bad. We found, allulose. We found erythritol. We found monk fruit. We found, we find these alternatives, and are they healthy? I don't know. I don't know. Nobody really knows, probably. So I think when you're talking about abstinence with food, it doesn't work. Like, you cannot abstain from food. If I could flick a switch and never eat again, I would flick that switch, because I don't want to deal with it. I would not want to deal with it. So, it's easy with alcohol. You just don't drink.
You just don't drink, but you let the tiger out of the cage
3
times a day, right? You let the tiger out of the cage 3 times a day. If you have food addiction, we have to eat.
You got it. So you have to learn to live with this addiction.
Mm-hmm.
So yes, I agree with the principle that abstinence, at least for a period of time, is necessary. But I'll tell you without any hesitation, harm reduction is you will have to learn. Do you eat broccoli? Well, how much salt are you going to put on the broccoli? How much bacon fat are you going to cook it with? How much oil are you going to cook it with? Are you going to put cheese on it? Are you going to put the Parmesan over it? That baked potato you have every now and then, do you put salt on it? How much olive oil are you going to roast it with? Right? What are you doing, and really why? What are you doing? Right? Tell me it's nutrition and not taste or substance. How could you?
Yeah.
Right? So you couldn't tell me. I could never judge you. Neither could I know if it's helping you or not. I mean, it's helping you. You've told me I'm much better now. I have starch. Do you
Mhm.
put olive oil and salt on it?
I measure everything.
Yeah.
I measure everything I eat is measured, but I'm a critical level food addict, so I have to. I'm a volume eater.
Yeah, me too.
Yeah,
100%. I am a volume eater as well.
yeah.
And I
We've
have
got
to.
we've only got so much time left, and I want to hit a couple of other
Yeah, hit
subjects
it.
with
Go
you, but
ahead. Let's do it.
because you've got some approaches on this that I think are important to the listeners. The two things I'd like to hit before we go is I know you visited the White House, and I saw you talking to Dr. Oz, and I just wonder what you think the barriers to public policy, like, um, once we get this food addiction idea out that it's real and it affects some of our population, harm reduction, whatever, and the big food companies. I wanted to spend time on that, but I don't think we have time. But the $1 trillion of money that the food companies make, and how unhealthy our country is and our world is just from eating ultra processed foods. And I know Bobby Kennedy, Dr. Oz, they're working on this, but what needs to happen? What are the barriers? And then I want to talk about the ICD.
Yeah. So it's complicated. I think right now food addiction can be treated um, under the auspices of obesity, binge eating, or you know a uh, eating disorder not otherwise specified. Right. So there are ICD-10 codes, but there's no coverage for health coaches. There's no coverage for apps. There's no coverage for community meetings. There's no coverage for any of this. And it doesn't look like any of that's changing in the interim.
Hmm.
There are technology avenues for companies like ours that we could explore that may reimburse us for outcomes on weight, blood pressure. So if we identify somebody with food addiction with a metabolic issue and we reverse those, there may be, but it does not actually measuring the food addiction and its effect, right? So there are some models that that metabolic clinics could employ, but I think it's largely going to be, unfortunately, a cash based model for the foreseeable future,
Hmm.
because reimburse unless certainly the ICD-10 or the WHO recognizes it, or it becomes an ICD-10 code. Binge eating is there,
As a
so you can use that.
psychological disorder.
Yeah, yeah. I think so. I think there's, you know, I think there's legitimate questions about, can you be addicted to food that are worth discussion in the scientific community. I understand why I am a food addict. I believe in food addiction. But I understand why the scientific community has some apprehension to it.
Hmm.
Um, so I don't think we should look to government or hospitals or public health to fix this. I think it's just going to be you, me, and the person in front of us that's going to fix this for the foreseeable future. I do think there are sympathetic ears right now at HHS to anything lifestyle based. There's huge grants in place. There's huge rural health monies mobilized. So if you're in the rural health in America, if you're looking to do a lifestyle first approach, there are grants, and there are directly with CMS and money at the state level that have been injected. So there's plenty of people with a little bit of know-how and a little bit of passion behind this that can make this happen. And you'll have to
Hmm.
leverage one of those, either the MAHA grants or the rural health grants, and go fix people, and
Yeah.
go fix people,
Well,
and help
fix
people.
people if they want to be fixed. I mean, it's one thing to understand what's going on and how bad ultra processed food and sugar is for us, but it's another to take personal responsibility and want to live differently. And that's the big change. I mean, imagine if everybody ate what they're supposed to eat, what would change in our country. Pharmaceutical sales would go way down, and our metabolic health would be better. But people have to take personal responsibility, and I don't know that that's going to happen. Do you think we'll see
Well,
warnings? Yeah.
I'm gonna challenge you on that. I've never met somebody who wanted to be ill. I
Wanted
have
to what?
never met somebody who wanted to be ill. So people need to take personal responsibility. Yes, but I was a physician. I had access to money, people, insight, and I had no way. Like, forget it. And I wanted to. I would have cut off a pinky to be healthy. So I haven't met somebody who doesn't want to be healthy. It's
but
just
do they
not
want to
there.
do what they need to do? You said something, which is what I said.
Then they have to be honest, right? I want food over being healthy, and then we move on.
Yeah, but you said something, which is what I said at the turning point, and that is, I want to live.
Yeah.
And I knew I wasn't going to live like that. So what do? I was willing to do whatever I needed to do, and
I've met
not everybody is.
Very few people, in my opinion. It's like saying, like, you meet, like, you ever met somebody who doesn't want $1,000? I've never met somebody who doesn't want $1,000. I've never met somebody, if there's $100 bill on the floor, they wouldn't go and pick it up. Is anybody willing to put the work in to go pick it up? I don't know. Probably. Most people would do. Just go pick that dollar up. So it's on us to develop the systems to make it easy for people to do the right thing and make the choices that are there.
To treat their food addiction.
Yeah. They don't have a chance right now. And like this whole personal responsibility, the reason why it makes me angry, the personal responsibility, because nobody has a chance right now. Nobody has a chance. It's an unfair battle. You're fighting like 50 food scientists in the grocery store. Our population doesn't know how to be healthy. Obesity spreads through our social networks. Literally, if you're fat, your friends are going to be fat, your family's going to be fat, and vice versa. Right? It spreads like a virus.
But there are people that come to you that are the people that come to you are ready to make a change and do something different.
Not everybody. We have to put some people. We have to turn some people down. We have to, because they're not ready for change. You assess their readiness to change. They're not ready for change. Hey, what are you doing here? Yeah, I can't tell you. I got yesterday. Somebody said, I'm going to sign up my mom. I was like, don't sign up your mom. She may not be ready.
Yeah.
Right? Like, don't sign up your mom. It's not going to work. I've been to this rodeo.
Yeah.
Sorry.
That's okay. Yeah. Well, hey, it's academic, agree to disagree or whatever. But I just think, I would love to see warnings on food labels and the government to do something about this in public policy, have treatment centers for food addiction, but I want to make sure we get this one in. As I mentioned, we were at the London consensus, the International Food Addiction Consensus Conference in London. And a few years ago, I'll set this up for the listeners, an international group of 40 clinicians, researchers reached a scientific consensus on ultra-processed food addiction, which meet the criteria for substance use disorder, similar to alcohol and drugs. So it's not so much a psychological disorder as it is a substance use. Showing a loss of control, withdrawal, continued use despite harm, which is what we talked about. That work has fueled the movement and the advocacy to include food addiction, specifically ultra-processed food addiction, as a recognized diagnosis in the World Health Organization's ICD that you mentioned, International Classifications, a classification of diseases, which would unlock standards for treatment, research, insurance reimbursement. You were one of the 40 that signed it. And I'd like to hear what you think about it and why you signed it and what do you think will happen?
I think nothing will happen, unfortunately, and not because of our efforts, but because change is decades in the making. I think there are a lot of legitimate questions. I'm hopeful at the WHO, but we need every listener's help. Unfortunately, we need their funding. We need time and effort to be able to lobby and talk and discuss and educate. I think nothing's going to happen. I think this concept is still very new, and I don't mean to be pessimistic. I'm so hopeful. I think we've put together a great, that like the group in the UK has done so much to move this forward. It's amazing what they've done.
Yeah.
So I'm hopeful, and I do think this is a polysubstance use disorder. And
poly meaning there are many foods that are addictive. Is that what you mean?
I think there's many ingredients and potentiators, right? So certainly like caffeine and sugar, let's say in Mountain Dew, right?
Yeah.
And the MSG that's added to the, Chinese food, let's say, would be another example, or Doritos, by the way.
Mm-hmm.
I think it's a polysubstance use disorder, and I think that this group, this consortium of 40 people, is absolutely what's needed. I know the Society of Metabolic Health Practitioners is behind this. I'm behind it. I know the HHS is aware of these concepts, and how we bring this to the forefront. I'm not sure, but I think things like the event that we had and the one in Poland, and who knows where 2027 will be. All of these will be important for moving the. But that wasn't your question exactly. What was the question exactly? Yeah.
You signed it. It doesn't sound like you're hopeful that it will pass. I think more research is going to be done. That's my opinion. Okay, let's do research, because it's been in there before and it's been turned down. And then Jen Unwin and Heidi have gone back and addressed all the objections they had and applied again. And there's been a time where you can sign, you can say, hey, I agree with this. And I think hundreds and hundreds of people have done that. So I'm optimistic that it'll happen, but maybe I'm just too hopeful or too optimistic that it will happen.
Well, I'm just not part of those. I'm not party to those discussions. So I'm hopeful for it. Like there's nobody better than them. There is nobody better than them to be advocating for this. Gosh, what an amazing group, and just to be part of the UK conference and the conference in Poland. It's just such an amazing group.
Yeah.
Definitely happy to be here. Happy to be there and happy to be a signatory. But we'll see. Like I'm just
we'll
like
see.
Jaded on politics and committees. So.
Yeah, it's a lot of bureaucracy to make progress, but I one thing at a time, right? Let me ask you one more question, and we close out here. It's kind of a signature question. I guess what I would say to somebody, I'd have a lot to say to somebody who wants help, that weighs maybe 150 pounds more than they should, how to go about it. I would probably direct them into recovery, weighing food. Here are your people. Here's how I did it, kind of thing. You've got a clinical practice around this. And so I just wonder what you would say to anyone here listening who, has eaten a whole pizza, has then had 2 or 3 Reese cups, and they don't know how to stop. Their family's worried about them. They're worried about their own health. And what would you say? Is there, about a solution?
I would get a Quest pizza, and I have no stock in Quest, and a Quest Reese's peanut butter cup, and I would start there. Just do harm reduction. Super
Harm
easy.
reduction. Okay.
Do a low carb version of whatever you're doing. Sugar-free, low carb version of whatever you're doing. Right? Just write down all your problem foods. Write them down. And then figure out a way that you're going to do better. That works for you.
That can be a start, but is it a solution, do you think?
No. It's just a start. And then 2, get a community. The Toward Health app is free. We have free meetings you can go to. Free.
Mm-hmm. Yeah.
Like free. You could just pop in, talk to somebody. Talk to a food addiction expert for free. You download the app for free. 3 times a week for free. Like, go
Yeah.
for free. If you need medical care, we'll help you.
Yeah.
You know, listen to Food Junkies podcast. Listen to this podcast. Listen to our
Infactual
podcast.
podcast. Yeah.
Yeah, listen to the Food Junkies book. Get it on audiobook.
Go to foodaddictioninstitute.org. That's our organization. We've got many, many articles on there, questionnaires, all kinds of books help. So
the simplest heuristic is if it makes you eat more, don't eat it.
Right.
That's it. If it makes you eat more, don't eat it. If it fills you up, eat it. Follow your own plan. If it makes you eat more, don't eat it, or figure out a way to deal with it. If it fills you up, eat a lot of it.
Yeah.
Like, eat it. Eat as, if it fills you up quick and for a long time, that's gold for you.
If I assume you have the same thing, that when you eat, you're full and you don't think about food, eating more. You have food freedom. It's not in your head, which it was in my head. Right.
I have a very unique genetic pedigree, and I basically never get full. So I never get full. Is
that the homozygous gene you're talking about?
Yeah, I don't get full easily. So that's why I've had to I'm more full with steak and eggs than I am with a potato or bread. But I don't have fullness the way most people do. It takes like 3 or 4 pounds of food to fill me up.
Wow.
So, yeah. I haven't checked my ghrelin, but yeah, ghrelin is the hunger hormone. Yeah, it makes you eat more. But yeah, gosh, I mean, steak will fill me up though. For sure.
I love steak. Steak's
steak
good.
Fills me,
good for you.
Broccoli just makes me bloated. The vegetables just make me bloated. They're great if if I just want to chew.
Yeah.
If I just want to chew, the vegetables are really good for a time like that.
A lot of vitamins in there if you get the right ones.
Yeah. If I'm sweet craving, I do like cottage cheese with some sweetener. Right. That's what I'll do if I have a sweet craving. Occasionally berries, but if I'm salt cravings, I'll do pickles. Or I'll drink bone broth. But the only thing, honestly, it's just I need protein to fill up, unfortunately.
Yeah. Well, looks like you're healthy now.
Thank
Congratulations on the weight loss and the recovery there, and keep doing the good work. To find Dr. Tro, you can go to towardhealth.com, and he's quite prolific on X. So there are a lot of posts during the day, and they're really entertaining in some cases and very informative. So thanks for joining me today. It's been great.
Thanks for having me.
Yeah.